So in the next few slides in this section, I'm going to discuss a suggestion for a diagnostic approach that you can use in clinical settings. And unlike what you may think, Alzheimer's is the most common cause of cognitive impairment in older adults. However, it remains a diagnosis of exclusion, which means that you have to exclude other causes before you consider Alzheimer's disease. So here's a suggested diagnostic approach to deal with these patients in clinical settings, which I will detail in the coming slides. First is history taking, which must include a reliable informant for collateral history, a physical exam including vital signs, a neurological assessment which should include speech evaluation and gait assessment, so you need to watch them walk and hear them talk, a cognitive testing, and then screen for depression, which is a famous reversible cause for cognitive impairment. Labs are needed to rule out any reversible causes. Brain imaging usually handy, either to confirm your most probable diagnosis or exclude other possibilities. Special tests may be needed as indicated, and then you reach a probable diagnosis with some differentials. So the first step, as I mentioned, is history taking from the patient and a reliable informant for collateral. That should include the onset, the course, and the duration of the illness. You have to screen for cognitive symptoms and neuropsychiatric symptoms. You should do a detailed assessment of functioning, including the activities of daily living and the instrumental activities of daily living. Obtain a good past history, including past psychiatric history, a family history of cognitive issues, possible exposures, whether it's occupational or environmental, and a social history, including current social supports. The physical exam can be crucial, especially vital signs and ruling out orthostatic hypotension. Body weight and their BMI can also be important. Doing a head-to-toe examination, and you focus on risk factors for cognitive impairment and alternate etiologies. You may need a focused neurological exam, focusing on the cranial nerves, pyramidal system, extrapyramidal system, coordination, speech, and gait. Cognitive testing, you may refer to the screening section in this module. Some may require more specific testing. For example, in frontotemporal dementia, they may require an in-depth speech assessment and a specific executive function testing to rule in or rule out. Testing is usually needed at presentation and is preferably repeated every 6 months, 9 months, and sometimes once a year. Screening for depression, I cannot emphasize enough how important this one is, because pseudodementia is not uncommon in this population. You can use the PHQ-9 or the Cornell scale for depression in dementia. You should also screen for other neuropsychiatric symptoms using either the Neuropsychiatric Inventory or the DSM-5 self-rated level 1 cross-cutting symptom measure, which the patient can fill out on their own. Next is lab work. This is the standard battery that we order for patients presenting with cognitive impairment. It includes a CBC, a metabolic panel, a hemoglobin A1C, screening for syphilis, TSH, vitamins D, B1, B6, B12, and folate, a urinalysis, and in some cases, a drug screen and HIV testing may be needed. Brain imaging. So the best initial is an MRI without contrast of the brain with volumetric measures if they are available at the screening center, or the MRI machine can do it. A CT head without contrast if the MRI is contraindicated or the MRI is not applicable. So some cases will require some special testing, like special neuropsychiatric testing may be required for special populations like illiterate patients. Lab work for autoimmune markers may be indicated based on history and exam. Genetic testing may be indicated for some patients. Advanced neuroimaging like a PET scan, a SPECT scan, a functional MRI, or a DAT scan A lumbar puncture, an EEG, and an EKG are sometimes indicated. So one last notice I have to say about this section is that good practice requires revising the diagnosis periodically as the clinical presentation evolves. It's not uncommon that you have a preliminary probable diagnosis, but as the picture evolves, you may need to revise your diagnosis and your treatment plan accordingly. Most of these diagnoses are only definitive by autopsy, so diagnoses are usually possible or probable, and follow-up is quite crucial. It's not just a park and go. You say this patient has a frontotemporal dementia, and that's about it. You should follow these patients because things may change and may evolve into different scenarios.